coming to us. And of course, the rheumatoid arthritis is also something, a big contributing factor, because there's an autoimmune disorder and these patients have been on certain drugs which cause osteoporosis. So what are the factors which cause, which affect osteoporosis? First is the alcohol abuse, low calcium intake. This is a lifestyle related, vitamin D deficiency, high salt intake, sedentary kind of lifestyle, and immobilization, as Dr. Shivang mentioned about smoking. There's a history of falling, excessive thinness of bones. So all these things are related to our lifestyle. Then there are certain genetic factors. Like this patient may be coming to us with something like connective tissue disorders like Ehlers-Danlos syndrome, Marfan syndrome, which we have also seen in our practice. Long, tall patients coming with very hypermobile joints. And osteoporosis is like an indirect sign of this disease. So patient is not going to tell us that this patient has got any osteoporotic signs over there. Or there can be metabolic disorders like Gaucher's glycogen storage disease or hemochromatosis. These are the certain common conditions which can, genetic factors where it is running in families, and hence if the patient is suffering from the disease or the parents have it, we know the children who's coming at the age of 25, 30 runs a very high risk of osteoporosis, and we have to take adequate precautions at that stage so that in future when this child reaches the middle age should not be suffering from osteoporosis. And then there's the hypogonadal states. Now these patients, like let me list out, this is, I can understand these slides are just boring list of diseases, but just remember these patients are coming with something else to us, and osteoporosis is an additional finding. So that is why this osteoporosis is so prevalent. These patients may come to us at the age of 40s, 50s with some fracture, and then we find, oh, this patient has got some hypogonadal state. Henceforth, these include anorexia nervosa, all this weight control, dieting, and all these things are contributing to it. Premature menopausal, premature ovarian failures, and so is this pituitary drive when it goes down. All this is responsible for the loss of estrogen support to the bones. Endocrine disorders. This is something very, very important and very common. Just most of the diabetics which are coming to our clinics, they are all having osteoporosis. Steroids, Cushing disease, Cushing syndrome, or adrenal insufficiency, thyrotoxicosis. These patients are coming from the medical side. They are having all the drugs taking care of their thyroid disease, and we investigate for some backache. We get the X-ray done, and these days every patient comes with an MRI. MRI does not tell us anything for the osteoporosis per se. It is maybe the plain X-ray or maybe the history taking, which makes us suspicious that this patient might be suffering from osteoporosis, and I need to work on those lines. So in our own practice, I don't blame this to orthopedic surgeons. I think most of the specialties, this osteoporosis diagnosis remain undiagnosed most often. We are always looking at the primary disease, okay, sugar controlled, diabetes controlled, go home, nothing else is required. Then this gastrointestinal disorders. Why these GI disorders are important? All these malabsorption syndromes are associated with the poor protein intake also. So this poor protein intake is responsible, along with the poor calcium metabolism, celiac disease, gastric bypass surgeries, and inflammatory bowel diseases, which are very common, and these patients are visiting the gastrointestinal surgeons or gastroenterologists, and osteoporosis remain undiagnosed for years together. How about malignancies? Well, in malignancies, we know that all these multiple myeloma, hemophilias, or leukemias, lymphomas, we get their blood reports done, they have hypercalcemia in fact, what we call as a hypercalcemia of the malignancy. So here the calcium reports or the vitamin D reports may be misnomer to us, because this patient has high blood calcium levels, he is suffering from malignancy, but his bones are very weak. These bones who have very thin trabeculae, which I am sure the next speaker is going to tell us about how these fragile bones look like, the cortical bones and the cancellous bones on the X-ray. So here we need to look at the primary disease. We have to take care of the primary disease. We have to prevent the osteoclast function, which means use of bisphosphonates, zoledronic acid, So all these are different drugs which work at different levels. Then how about the rheumatological disorders? These patients like ankylosing spondylitis, rheumatoid arthritis, which are so common, they may have a young patient coming with a stiff spine, and we treat it with so many drugs to control the joint problems, and but the osteoporosis remains undiagnosed. We hardly tell the patient about the exercise therapies, we don't tell the patient about the protein therapies, about the calcium and vitamin D. Somehow it is a market driven. That's why we talk a lot about calcium, vitamin D. But believe me, a lot of floors, this is what we're discussing, Dr. Wang was discussing 10 minutes back. We are flooded with the formulations of calcium and vitamin D together. And I think it should be vitamin D and calcium should be used separately more often. And then calcium we know judiciously that how to carry on so that vitamin D toxicities don't happen so frequently as it is being talked about. All these toxicities are happening because most of the preparations are coming with the fixed drug combinations. Henceforth, we end up in having vitamin D toxicities which we didn't think before. Then certain central nervous system like epilepsy. Epilepsy patients have been taking phenytoin and sodium for years together. And as these children grow and then by the time middle age, these patients, if you look at their x-rays, they're absolutely featureless, plain x-rays, and they're osteomyelitic spines, and they present as osteoporosis as well. And same is true for the spinal cord injuries and stroke patients who are, because of the immobilization, they develop these osteoporosis. What are the other conditions which can affect, which are the risk factors, which we must know while taking the history and examination of these patients and start thinking that this patient might be having osteoporosis? Is, for example, these patients who are depressed, pretty common. Post-transplant, renal transplant has happened and they are on immunosuppressant drugs for years together and they are bound to develop some kind of osteoporosis. Weight loss, which is, everybody is talking about weight loss, whether by dietary control or by the bariatric surgeries, and the osteoporosis remain undiagnosed very often. There are certain drugs. There's a long list of drugs, but I'm trying to emphasize only the important features, important drugs. Like, for example, the steroids, more than 5 milligrams over 3 months of period of time, the risk of osteoporosis is going to be very high. Not a short course of steroids, which asthmatics take it for a week or 2 weeks. I mean, if we have used it for over 3 months' time, then probably osteoporosis is a big risk factor. Then, of course, methotrexate is another drug which we use for rheumatoid arthritis. Parenteral nutrition, if some patient has been in the hospital for some other reason on parenteral nutrition and this osteoporosis remains undiagnosed. We're not thinking about the silent killer. We're talking about all other serious illnesses. Tamoxifen, which already been mentioned about for the malignancy patients. So osteoporosis is related to certain diseases. Osteoporosis, we know sometimes we pick up osteoporosis once a patient has got a fracture, and then we know osteoporosis is the underlying cause for it. But then, is there anything else which put these patients at a risk? That's a risk of fall. How can we minimize this? Which is very, very important. I think this slide is the most important slide in the presentation. That there are certain environmental risk factors. These old patients, whether men or women, if we need some assistive devices in the bathrooms, which means like have some handles near the toilet seat so that they can take their help while getting up or taking bath. They should be, if in case they accidentally slip on the floor, they can actually hold the handle quickly and control themselves. All these things are really important, which we usually ignore in our fancy bathrooms. Then these loose throw rugs, which are very common. We have all these carpets and nice paidans lying in our bedrooms, and very often, and these old patients, they have their they get their foot stuck into it and they fall and they land up with a very morbid fracture. So we should avoid these. Especially these older people should avoid having all these carpets, etc. in their bedrooms. And then low-level lighting. This is a very important thing. I mean, just to have a good-looking bedroom, sometimes the lighting is not enough. the visibility to this poor man who's got already a cataract or some kind of a poor eyesight, and the poor light is responsible for it. We face this problem very often. As an orthopedic surgeon, I'm sure Dr. Shumang would agree, we get all this common history. I fell in the bathroom, I fell in the bedroom, but we never go into the details that what actually went wrong. We don't go back, check your bedroom or bathroom, please correct that. We hardly do that. We end up in fixing the fracture nicely and make the patient walk. And then any obstacles in the walking path, where the patient has to walk through, is that passage clear? They're not small stools or wires crossing on the floor. Slippery conditions, we have nice marble floors, and all this are responsible for, we have to make sure that these slippery floors are not available to these osteoporotic people. And of course, there are certain high risk factors where these patients have got kyphosis or reduced proprioception, poor balance, weak muscles. All these are responsible for these patients to have a high risk of fall. There are certain factors which indirectly put these patients at a risk of fall, which include anxiety, age, arrhythmias, dehydration, depressions, and malnourished. There are certain kind of medications, maybe some sleeping drugs, as they are very drowsy. There may be poor vision, bifocal lens. There may be previous history of falls. So they might have one fall has happened, maybe a lower end radius or a minor injury, and it has been taken care of, but we overlook that this we haven't rectified in the living style of this patient, and now he comes with a major fracture neck fever or fracture shaft fever to us. And of course, urgent urinary incontinence. Most often, these old men and women, they are going in the middle of night, rushing towards a washroom to ease themselves, and they land up with a fracture. So all these things have to be looked into if we want to take care of osteoporosis overall. And last of all, the fear of falling. They may not be major risk factors, but these old people, they have a fear of fall. So this kind of reassurance is also equally important to rehabilitate them properly. So these last few slides, there is something called bone mass assessment, and we know if the bone mass is less, the risk of fracture is higher. Probably I think I leave these slides to the radiological assessment. This slide has already been talked about. And I've already discussed the various factors which control the bone mass. Virtually all the factors which I've discussed before, they contribute in osteoporosis. There's something called fracture risk assessment model. Well, we haven't ever used it. In fact, this thing is not available to us in India because we don't have a very good Indian data to support it. And at the moment, I would still keep this FRAX assessment at lower on priority. So it is basically based on a questionnaire. We ask lots of questions to the patient and then feed the data, and bone mineral density assessment is done with the DEXA scans, and we compare the two. So what is the future for the osteoporosis? Will it be a silent killer forever? And all this entire presentation is based on please suspect osteoporosis. Don't diagnose osteoporosis. I think when we are diagnosing osteoporosis, it's already very late. So let's suspect osteoporosis, but the future lies in the fact that someday we just get a blood test done and some genetic markers are picked up and say, oh, this patient is going to have osteoporosis. So there is some research going on in some bone formation and bone resorption proteins which will be identified, but at the moment it's all on the experimental background. With these words, I thank you very much.
You have told about the so-called boring list, and like the patient comes to me, how many questions that must be asked to every lady, like to our specialty? Simple thing in history and to diagnose. So we can take the history of family history, we can take medicine history if she is taking any, and the other things are not in our hand. the difficult ones.
Ma'am, I really appreciate your concern and your
Somebody
performer.
takes the effort and gives us the
Yes, sure. I think I can work on it, and probably I will need your support also. And yes, it can be worked out.
history and
Yes.
Excuse me, sir. Menopause Society has given a flow chart just to for the management of the osteoporosis, and it is available on the site. And I will be also discuss.
Is different even from a 75 or 80 years old.
That's true.
And I don't think so. If my parents are 70-year-old, if I tell them they're old, they will not like me. I'm sure they have some reasons to live on, and they have to carry on.
Yeah, so the take-home message is that we should be aware, and we should, of course, try to find out whether we are at risk or not, and
Yes,
the
absolutely.
condition should be diagnosed as early as possible so that it can be treated.
Yeah.
So. Good afternoon and warm welcome to all of you. Change in the law of life, challenge, and let us move together and aim to achieve goal of fit at 50, strong at 60, and independent at 60, at 90. As per the recent report of International Osteoporosis Foundation, 50 million Indians suffer from osteoporosis, which is a silent killer. 1 in every 2 female and 1 in every 8 male suffer from osteoporosis related fractures sometime in their life. Acute and chronic backache, and if there is a loss of height more than 1.5 inches, that gives suspicion of vertebral compression. So osteoporosis is a global problem with increased fracture mostly at right, which is detected by horizontal trabeculae, cortical thickness and porosity of bone. Today Dr. Harkaran Singh Maan, who is a young dynamic personality in around us, is going to enlighten us with latest technique of radiological diagnosis of osteoporosis. He graduated from Amritsar Government Medical College and did post-graduation
A little bit nervous. This will go away. We as radiologists are these days having lot of vitamin D deficiency, and simply because of the fact that we people work are night crawlers. We are working in dark rooms from morning to night, and then when we get our vitamin D levels checked, they are always low. So we are more susceptible to osteoporosis than an average adult. I would like to thank Indian Menopause Society for giving me this opportunity. I saw the parts that have already been discussed, the pathophysiology and the causes. What is osteoporosis? Osteoporosis in simple terms, as discussed, is quantitative abnormality of the bone, means too little bone. Bones become brittle and fracture with little or no trauma. These are also called insufficiency fractures. Osteoporosis should not be considered as a single disease entity, but rather an end result of many disease processes. Alternatively, it may result from disease processes in which bone resorption exceeds the new bone formation, resulting in net loss of bone mass and consequent compromise to skeletal strength, as discussed in the previous lectures. What WHO says, as written in our radiological books, is a skeletal disease characterized by low bone mass and microarchitectural distortion of bone tissue, with consequent increase in bone fragility and susceptibility to fracture. That is how WHO classifies it. And with the introduction of the non-invasive methods of bone densitometry, it is possible to define osteoporosis on the basis of bone mineral density, the BMD. We will be discussing this a lot today. Measured at hip level and at spine by DEXA. dual energy X-ray absorptometry. This is the WHO defines is there in a lady. The definition is now also applied to males. More importantly, not appropriate in children or adolescents who have not yet reached the peak bone mass, because the standard what DMD is standard for the adults with young adults with mean reference peak bone mass range. The WHO definition is not acceptable to other bone density techniques, which are quantitative computed tomography, quantitative ultrasound, not practiced commonly these days, and at other anatomical sites other than the hip and the spine, which is the calcaneum or any other bone. Now the causes will be concentrating more with the postmenopausal osteoporosis, but many causes have been discussed also by Dr. in the earlier lecture. Now, generalized osteoporosis. What is generalized osteoporosis? There are many causes. It is categorized into 4 categories. Factors which reduce peak adult bone mass, age-related bone loss associated with menopause or hypogonadal state, bone loss that is secondary to other medical conditions and drugs. Now, pathogenesis. We have already discussed the role of the osteoblast, osteocytes and the osteoclast. Osteoblasts are the bone forming cells, osteocytes are the bone maintaining cells, and osteoclasts are the bone resorpting cells, the cells which absorb the bone. I will not be discussing other causes. Postmenopausal osteoporosis. At the time of menopause, lack of estrogen will result in some women losing trabecular bone at the rate 3 times greater than usual, about 2 to 10% per annum, which is significant. The condition previously was referred to as type 1 osteoporosis. Characteristically became clinically evident in women 15 to 25 years after the menopause. The fractures occur in sites of the skeletal rich in trabecular bone, like the spine, including the vertebral bodies and the distal forearm. The Colles fracture is very common in menopausal women, as we see. This has been segregated from the senile osteoporosis. Previously, it was type 2 involutional osteoporosis. This occurs in both men and women equally after 75 years of age or older. This occurs as a consequence of age-related impaired bone formation associated with secondary hyperparathyroidism caused by reduced intestinal calcium absorption due to decreased levels of vitamin D production in the elderly. There is reduction in both cortical and the trabecular bone as compared to the only trabecular bone in case of menopausal osteoporosis. The syndrome manifests mainly as hip fractures and wedge fractures of the vertebrae, also commonly seen in menopausal. But fractures may also occur in proximal tibia, proximal humerus and pelvis, not commonly seen in menopausal osteoporosis. Now, radiologically, what methods we use for quantitative skeletal assessment? Morphometry is the first. Standardized measurement of cortical thickness on X-ray, trabecular pattern on X-rays given by Singh's index and worldwide accepted, and vertebral deformity, which is the morphometry from the radiographs. Two other methods, radiographometry, which involves measurement of the radiographs of the cortical thickness of various long bones. The bone most frequently used in the is the second metacarpal of the non-dominant hand. But the method has also been applied to other bones like clavicle, radius, humerus, femur, and tibia. Vertebral morphometry, which is the most commonly practiced. With the introduction of the fan beam technology in X-rays, DEXA was discovered. It has enabled good quality images of the thoracic and lumbar spine, from which instant vertebral assessment and morphometric assessments can be made, which is done automated, which is an automated computer-aided diagnosis that we get. Now here, this is the radiograph of the hand, the radiography of the hand, where we see that this is this method we can see the cortical thickness in the mid shaft of the second metacarpal, of the non-dependent hand. This method is no longer used these days because of the better methods like DEXA available to us. The morphometry of the spine in this image, we see that we take 3 points at the anterior-most point cranially, caudally, the middle, and the posterior aspect points. And these are calculated. From these are calculated the ratios of anterior to posterior heights. This wedge we can calculate this wedge. Middle to posterior height and posterior height of one vertebra to its neighboring vertebra. And the vertebral deformity is defined by relating the anterior or the mid vertical heights to the posterior heights expressed as percentage. 15% mild, 20% moderate, or 25% severe deformity, or by specific standard deviations from normal reference stage. A vertebral fracture can be defined by grading from 0 to grade 3, which is an obvious fracture, grade 3, and a semi-quantitative scheme which is now largely replaced the 6-point morphometry. As I say that these are not longer in radiological practice these days, but for your reference, because DEXA has overtaken everything. Now, X-ray beams of 2 peak energies are produced by a variety of techniques, which in X-ray we call K-edge filtration and energy switching. This allows rapid data acquisition and improved spatial resolution. The higher the photon flux enables lateral imaging of the entire spine. So I'll not go into details of the physics of the X-ray in this. In short, DEXA is the gold standard. Outcome is measured at bone BMD, the bone mineral density. Measurements vary by sites. Hip site, best correlation with fracture risk. Vertebral site predicts vertebral fractures. There is also risk of high scores, we'll discuss that later. Now, why DEXA? DEXA is compatible with WHO T-scores. We discussed them earlier, standard deviations -1, -2.5, 1 to 2.5. They are proven to predict fracture risk. They are proven for effective targeting of anti-fracture treatment by the treating orthopedicians and the gynecologists. Suitable for patient follow-up. They are stable calibration. They have very good precision. Reliable reference ranges are available online and also provided with the report. Scan times are short, and the major plus point, very big plus point, very low radiation dose. So whole body DEXA with regional analysis gives information not only on bone density but also on body composition. So we also mentioned the amount of fat, percentage fat. We get patients who just get the DEXA to see how much weight they are losing every month. Since the X-ray dose is very low, it is relatively safe. 1/10 of a background radiation dose that we get from the environment. DEXA measures integral BMD, the trabecular and the cortical. It differs from various sites in the body. The ratio of trabecular bone to cortical bone is almost 50-50 in the lumbar spine. That is why lumbar spine is most commonly affected in postmenopausal women, because trabecular bone is most commonly affected than the cortical bone. The lateral projections of the lumbar spine, and in the proximal femur it's about 60-40 and 80-20 in the whole body. Measurements are of integral bone and projected areal rather than true volumetric. True volumetric we get in quantitative CT scan, but that has its own problems. We've already discussed the interpretations. T-score is standard deviation of BMD from average sex matched 35-year-old female. Z-score is not used these days. Osteoporosis is seen when the T-score is less than 0.25 standard deviation. Osteopenia is between -1 to -2.5 standard deviation. With every -1 decrease in T-score, the fracture risk doubles. So if it's -3.5 standard deviation, the risk will be double for a fracture in the lady. What are the current guidelines? test mineral density in all women greater than 65 years of age, and in younger postmenopausal women, women with at least one risk factor, postmenopausal with a history of a previous fracture. Now, recommendation for DEXA scan in Indian females. All women 5 years beyond the age of natural menopause, women less than 5 years since menopause with a particular risk factor, women with fragility fractures, women in menopause transition with secondary causes, radiological evidence of osteopenia, presence of vertebral compression fracture, before initiating any pharmacotherapy for osteoporosis, get a DEXA. Before starting patient or anything, get a DEXA. That is what the standard says. Now, this is how you will see the report of a DEXA scan. You will see a spinal radiograph taken in a very low background X-ray exposure, and a graph will be plotted. The BMD score, this is the standard deviation graph already given by the machine. This signifies that this is more than -1 standard deviation if the bone density score is over here, which means that this lady is